I'm Brittany Lewis, a breaking news reporter here at Forbes. Joining me now is Z Reitano, co-founder and CEO of Row. I do want to take a step back here, and like you said, you could break down the differences between the oral and the injectables, as well as the difference between Wegovy, which is a big name, and then Ozempic, which is a type 2 diabetes medication. Can you break all that down for us?
So, happy to explain the differences between orals and injectables and Ozempic and Wegovy and some of these other drugs. It's a very long conversation, so I'll do my best to do it quickly. But Ozempic and Wegovy are both are different brand names for the exact same drug, which is semaglutide. And semaglutide is part of a class of drug called GLP-1s, which some people may have heard. GLP-1s, the class of drug, have been around for about 18 years. So originally, as you mentioned, to treat type 2 diabetes. About 5 years ago, you saw Ozempic come on the market, which is FDA approved for type 2 diabetes. And that is, again, semaglutide. And it was patients saw, while it was originally approved for type 2 diabetes, patients who were using it, they saw patients lose weight on it really effectively. And so they then ran additional studies at different doses, showing that it could be used for patients who have overweight or have obesity. And there's a few different criteria, but the criteria for Wegovy, which is the FDA-approved version of semaglutide for weight loss, again, this is a lot to follow here. The label for Wegovy are patients who have a BMI of 27 with comorbidity or a BMI of 30 plus. And yes, there's a whole host of complications with BMI, but that is what has been used by insurance companies and the FDA in terms of on-label use for FDA-approved weight loss medications. Both Ozempic and Wegovy are once-a-week injectables. So they're subcutaneous injections, relatively painless for patients, and patients take them once a week. One of the challenges with injectables, in addition to some patients having fear over injecting themselves, is the fact that they are these large molecule drugs. They can be very expensive to produce, and they have a shorter shelf life. They need to be refrigerated. You need to in order to ship them, they have to be cold chain shipped. And so there are new oral medications that some are of the exact same active ingredient. So some are also semaglutide with a different brand name, but others are of the same GLP-1 class or GLP-1 and GIPs. You recently saw Eli Lilly announced what's referred to as Triple G, which is another weekly injectable. So there's this new wave and this new class of drug with very similar either single action, dual action, or triple action mechanisms, all around the same goal of helping patients with their cardiometabolic health. And so you saw Ozempic approved about 5 years ago, you saw Wegovy approved about 2 years ago, and you're seeing a tremendous pipeline more recently, all in a similar area to help patients who have overweight or have obesity, as well as underlying comorbidities. And I'm happy to talk about some of the results that we're seeing, but at a very high level, you're seeing reductions in A1C, reductions in LDL, increases in HDL, improvements in quality of life. So while people are talking a lot about weight loss, and that has been the primary endpoint for a lot of these trials, we are seeing significant improvements in patients' underlying cardiometabolic health in a way that hasn't really ever been seen before. And so it's really an exciting space to be in. And I think we're at the very, very early stages of sort of a new era in medicine and the treatment of obesity as a disease.
And the psychological results must be astounding as well. But I'm a little curious here because obesity is not a new problem. As you said, I believe 43% of Americans are either overweight or obese. So why is there such a stigma around these types of drugs?
It's a great question. The biggest reason, and again, this is sort of one person's opinion, but the biggest reason that I think there's a stigma towards those who have overweight or have obesity is that it is falsely seen as a disease or a failure of self-discipline or a failure of willpower. So there aren't very many health conditions where when you look at someone who has that health condition, that the majority of people immediately make a snap judgment about that person. They make a judgment that they don't have as much self-discipline, or they don't diet and exercise, or they don't do the things that you need to live a healthy life. And I think what we've learned is that's largely not true. Similar to other chronic diseases, there are significant genetic components, significant environmental components, in addition to behavioral components. And the more that we learn about obesity, the more that we learn that it's a neurohormonal, both progressive and relapsing disease. And these medications are sort of case in point, they're proof of the fact that there are biological processes going on in someone's body that is far more outside their control than people had originally realized. And I think that that is hopefully what's going to break down this stigma. But people view it because they view that there is a solution, which is not true, that there is a solution for the majority of people that just requires a different set of behaviors. They judge those who are using treatment to see the level of success that they have. Now, if we replaced, what I think is really, really fascinating is whenever I think people potentially are exhibiting bias towards those who have obesity or have overweight, a really easy way for you to sort of realize or see if that's the case is to ask yourself if we would react the same way if we replace the word obesity with diabetes or heart disease, right? 80 to 90% of patients who have diabetes also have overweight and have obesity. And obesity, as we talked about before, is associated with 8 out of the 10 leading causes of death. And so there's a tremendous stigma against it. And these medications are so effective, and there's sort of a false perception of the solutions that are best used to treat it. And again, we can talk about the differences between treatment and prevention, because I think that's a whole nother category of discussion here. But I think that is largely the reason why there's historically been such a stigma around it. I think it's a largely misunderstood disease, a chronic disease, and that misunderstanding leads people to view those who struggle with the disease very differently and unfairly.
Something that's really striking me in our conversation right now is you are continuing to say someone has overweight, someone has obesity. Can you explain why your language right now is so important?
I think that I'm glad you noticed that. I think at this point it's very natural for us and our team. But the primary reason is that we don't want to define people by the disease that they struggle with, right? So I think that there's been a large and important shift in medicine when speaking about patients who have certain illnesses to transition from someone is a diabetic to someone has diabetes, right? Someone should not be defined by their illness or their challenge or their health state in any way. And so I think, again, that's very, very important here, especially given the disproportionate stigma attached to those who have overweight or have obesity. And so we try to be very, very intentional with our language. And I'm glad you noticed.
I noticed right away. But something else that I've noticed in headlines is when it comes to drugs like Ozempic, Wegovy, things like that, the headlines are, oh, they're just shedding weight for a wedding, shedding weight for aesthetic reasons. But are these drugs actually life-saving too?
So the treatments have only been studied Ozempic has only been studied in patients with type 2 diabetes, and Wegovy has only been studied in patients who have a BMI greater than 27 with a comorbidity or those who have a BMI of greater than 30. And so for Roe, those are the only patients who have access to treatment. And those are the only situations in which insurance is covering treatment. So for us, we really focus far more on who is on label for these different treatments, and then we work towards getting coverage for those patients. What I would say more broadly is related to certain people is that for whom this medication is clinically appropriate, it can be life-changing. And I think that there are instances in the press, and there are no doubt instances out in the world where people who aren't clinically appropriate for the medication are getting access to it. And I think that has obviously that shouldn't happen. But two, I do think it clouds the discussion around how important it is to make sure that we can increase access for those who are, because truly the majority of the US population is clinically eligible for either Ozempic or Wegovy. The challenge has been insurance coverage. The challenge has been there's a national shortage of the drug, which happy to talk of Wegovy, and there has been shortages of Ozempic. Again, happy to touch on that and what Roe is doing through the shortage. But I think that overall, that's how we think about it.
Let's talk about some of the challenges that these drugs are facing, specifically Wegovy. As you said, there is a national shortage. Can you speak more to that?
Yeah, so Novo Nordisk, the manufacturer of both Ozempic and Wegovy, they've announced that there is a shortage of some of the initial doses of Wegovy, so 0.25 milligrams, zero point 0.5, and 1. And they have stopped the majority, if not all, of top-of-funnel promotional advertising. So this shortage is causing challenges for patients, for providers, to deliver the highest quality care for patients, as well as pharmacies themselves, right? As patients come in, pharmacies are having trouble making sure they have enough stock to deliver for patients. So we did a few things once the shortage was announced. One of the first things that we did was we stopped all top-of-funnel advertising, all TV, all radio, and any ad with the mention of Wegovy in it. We simultaneously notified all patients of the shortage, both before they sign up, as they sign up, and along their journey. We've added additional GLP-1s to our formulary, so additional treatments in addition to, where clinically appropriate, prioritizing Ozempic, where patients are eligible. We've also added Saxenda, which is a daily injection, also a GLP-1 that's FDA approved for weight loss. And we have consistently increased the number of pharmacies that we will call on behalf of patients, 5, 10, sometimes 15 pharmacies to find stock for patients, and then proactively messaging all patients what we're seeing on the ground. So while Novo has actually only announced shortages of 0.25, 0.5, and 1, we are seeing patients start to have challenges accessing other doses of the drug as well. And so it has presented challenges for patients, providers, and pharmacies alike. And so what we are trying to do is be exceedingly transparent with our patients, do everything we can to find them access to the medication. If they're unable to, we are issuing credits to them so that they're not paying for the service as we navigate the shortage together, and working hard to add additional treatment options. But it is definitely, it's definitely causing challenges across the board, and I think really does highlight the need for this treatment. We've never had a treatment that's ever been invented where the majority of the US population both wants and needs access to it.
Clearly, the demand is exceeding the supply here. So do you see that changing anytime soon?
Novo has given guidance that the shortage will subside in September, but I'm not so sure that will be the case. I think we'll have to wait and see. I think that the best thing that can possibly happen is that additional manufacturers come online. So there's another drug called Mounjaro, which is currently FDA approved for type 2 diabetes, but is being expedited and under review for FDA approval for the treatment of weight loss. And as I mentioned, there's a tremendous number of new innovative treatments in the pipeline. And in addition to that, Saxenda, which is a daily GLP-1, again, that is set to become generic in the not too distant future. So I think that in the near term, it'll be very difficult for manufacturers across the board to keep up with the demand simply because it is so significant. But I think over the next 12, 18, 24 months, once demand becomes more predictable, once more manufacturers come online, I think that hopefully we will be able to solve this challenge as a healthcare system.
As you really underscored, the amount of Americans who want or need this drug is really significant, but the price is really eye-popping. It's $1,349 a month. So first, does insurance cover this at all? And second, how does the average American afford this?
That is the central question. So right now, one of the value propositions that the Robody program offers is what we refer to as the insurance concierge. So we will collect the appropriate information, we'll verify a patient's benefits, we'll contact their insurance company. If needed, we'll go through appeals. We will really do our best to maximize the chances that our patients are covered. We do see the majority of our patients being able to achieve some form of coverage and assistance in paying for these drugs. Having said that, if the majority, if 50+% of them are seeing coverage, it still does mean that about 40%, just over 40% are not. And so where patients are seeing coverage, and then we can say where they're not seeing coverage. So where patients are seeing coverage is either if they are clinically eligible for Ozempic and Wegovy. What I mean by that is they are on label. So again, Ozempic is approved for those who have a confirmed diagnosis of type 2 diabetes most frequently. And then Wegovy is approved for those with a BMI of 27 plus with a comorbidity or a BMI of 30 plus. We do see our ability, let's say with Wegovy, to get the majority of patients some assistance, but they are limited by their insurance plan. And so I'll call out in the federal government has been tremendously forward-looking here, and starting in January of 2023, they've started to cover anti-obesity medications for all federal employees. So I think that the government has recognized for all their employees and their families that obesity is a disease that deserves access to the highest quality and most effective treatments. You see some forward-looking companies start to cover this medication because they see both the short-term benefit that it provides patients in terms of improved, lowered in a single year. You see lowering of A1C, lowering of LDL, increase of HDL, lowering of blood pressure, improvements in quality of life. So you see reductions in absenteeism and in presenteeism. So you can see a short-term improvement in productivity as well as retention. We did a survey with the Obesity Action Coalition highlighting the fact that the importance that employees will hold, and the importance that employees have in terms of their desire to work at a company that will cover this. We've seen actually 50% of patients will stay at a job that they dislike if it means that their medication will be covered, and 44% would actually quit their job and go to another one if they covered it. So we do see forward-looking employers see it as a short-term benefit to the patient, to the employee in terms of an improvement in their health and quality of life. And long-term, I think we are going to see studies show that it dramatically improves the quality of life and reduces macro and micro cardiovascular events and reducing instances of hospitalizations and severe health challenges. So that's where we're seeing coverage, forward-looking employers, the U.S. government. Where we are not is extremely cost-conscious employers who generally shift towards a short-term mindset. So if they have a high employee turnover, their incentives are such that they are not incentivized to care as much about the long-term health of their employees. And so they're unwilling to make that upfront investment given the cost. For those who are not covered, so that's what we see. Ro is able to offer the majority of patients some cost assistance through the insurance concierge, but it's complicated. There's tremendous back and forth. And our hope is that employers do start to match the federal government and see the benefit of covering these transformative medications. For patients who aren't covered, you are absolutely right. It is the cost is untenable for the majority of Americans. $1,000 a month for a medication as effective as this, as powerful as this, it's egregious. It's too much. And I think that the way out of this, which I'm excited about, because I think that this pain point with the efficacy of these new treatments has the ability to highlight the distorted incentives in our healthcare system. And we at Ro sort of have this philosophy of we never bet against the patient. We never bet against what they want and what they need. And they have voiced so loudly and so clearly and so vigorously that they want and need and deserve access to this treatment. So while it's $1,000 now, as you mentioned, there are some that are $1,000, there's some that are $1,300, some that are $1,500. That is egregious and way too much for the majority of Americans. And so I think it does highlight those who are able to pay cash. It highlights the inequality that has existed for far too long in the U.S. healthcare system. But competition, we do believe will be the thing. Competition and government pressure will be the thing that drives a significant and hopefully fast decrease in price. The more that we see, not just Wegovy or Mounjaro is going to be approved, but you see Pfizer has GLP-1s in its pipeline. You see AstraZeneca, you see Viking, you see Boehringer Ingelheim. You see some of the largest and most powerful pharma companies in the entire world striving or battling for the same and vying for the same market. That will be wonderful for patients. That level of competition will hopefully drive down the price. It might take a few years. But I think our job, and when I say our, I mean our collective job in society, should be to recognize the extreme prices that are currently in existence, recognize the desperate need that patients have and the tremendous overall health benefit to our system, and then work as a unit to create that competition and to compress the time in which more and more people have access to these treatments, because it is inevitable. We see this time and time again, whether it's statins. When statins first came out, they were $8,000 a year in terms of today's dollars, and the New York Times wrote that it would revolutionize cardiovascular treatment. And now you can get a year supply of statins for under $50, right? And if you're part of Amazon Prime, I think you can get it basically for free. So that will happen here. The patient demand can't be ignored, so the genie's out of the bottle. But I think our job as society is always to compress time and to shrink the amount of time in which only few people have access to the future. And so that's what we're trying to do at Ro. We're trying to leverage technology to overall decrease the cost and increase access to these new innovative treatments and to the highest quality obesity care. I know that was a mouthful of an answer, but you asked about costs in the healthcare system, so I couldn't really help myself.
No, I loved it, and I'm sure the viewers will too. And I'm really curious about your take on what this all means and what this all says about our healthcare system. When there was a Wegovy shortage, there still is, but when you wrote something about it in the middle of June, and I'm going to read that to you and I want your response. You wrote this: obesity is the most common chronic condition in the U.S., and patients deserve so much more than the healthcare system has delivered. So do you think currently, as we sit here today, the healthcare system in the U.S. is broken?
Yes. I don't think it is a novel statement for me to say that it's broken, but I sort of grew up on the philosophy of the best way to complain is to build something better. So it's really easy to critique. It's really easy to sort of sit here and say, here's all the ways that the healthcare system is broken. But I think that the best way is to try and build something better. And so that's what we're trying to do. That's what rowers wake up every single day dedicated to do. And in terms of what I think this particular treatment or this wave of new treatments can do, is it can really hold up a mirror to our healthcare system and highlight the distorted incentives. Because so many people want this and so many people need it, I think it will shine a light on the most distorted areas of our healthcare system, where you will see employers, you'll see the quotes that are given from benefit managers or employers. They'll start to focus primarily on cost, where I think if you just take a step back, and if cost weren't an issue, and again, it is an issue and it's a real issue, but just ignoring it for a second, if we just looked at the results of the medication, we would be asking ourselves, how do we get this to everyone who needs it? But given the cost, you see the initial reaction and the initial conversation be, it's too expensive, we're not going to cover it, or how do we prevent people from getting access to it? And I think that does highlight some of the challenges in the healthcare system. One, the role that employers play, the role that insurance companies play in terms of playing gatekeepers to these new innovative treatments. And I think you see, that system set up tremendously inflated cost of these medications. It is not by accident that these medications are $1,500 in the US and $150 in other countries. And even when you see $1,000 or a $1,500 price, no one is paying that $1,500 except for the patient. When an insurance company is not paying it, pharma company is not receiving $1,500, no one is paying that list price except for the person's insurance. It's like painfully ironic, but the only person paying that $1,500 is the patient. And so I do think that this entire class of drugs and the level of efficacy they have paired with the significance of the pain point for patients will create this confluence of events that shines a light on all of the problems of the healthcare system and create this sweeping momentum from patients and from builders like us and other healthcare providers in the ecosystem. And I think the next 2 to 3, 5, 10 years will be incredibly exciting. And I don't think it is an overstatement to say that both the treatments that are available now and the ones that are on the horizon and our understanding of the mechanism underneath them will lead to the potential for us as a society to truly eliminate obesity. And I think it's on all of us to see how fast we can do that.
So what you're saying is you believe in 5 years, the entire United States healthcare system, you believe, could be overhauled?
I don't know if we could do it in 5 years, but I do think that I love the famous quote. I think people overestimate what they can do in 1 year and underestimate what they can do in 10. I don't think our healthcare system is going to be overhauled by those on the outside or those on the inside. I actually think it's going to be us finding ways to work together, both the established healthcare system and new entrants, sort of the incumbents and insurgents working together in that way. Um, and I think that the fastest way to overhaul or improve the healthcare system is to put as much power and control over the flow of money in the hands of patients. The more that patients get to determine what good healthcare looks like, the more they get to vote with their feet, the more they get to control the dollars and who earns it, the more that the healthcare system has to compete over who can best serve patients. And it'll mimic other consumer and individual driven industries that more mimic competitive, rational market dynamics. And I think that that's what we're seeing. That's what we've seen in the cash pay universe of healthcare. But the cash pay universe is not all encompassing. And I think that we need to bring that same level of competition into the established and insurance-based healthcare system. That's really what the core of Row is this idea of empowering the patient, working backwards from the goals that they have, and delivering the most effective and most convenient solutions, whether that be us taking on the complexity of a cash pay experience or an insurance-based experience. But while it's maybe not 5 years, I do think it is absolutely possible and therefore worth trying.
Z Reitano, thank you so much for your insights. You're welcome back anytime.
Thank you so much.